The countdown has started, Vinay.
No, not yet. I'll start. We'll give 1 minute now.
Hi,
Yeah. The countdown.
everyone look very gloomy and
No. We had already chatted. Now the countdown is going to start. So
okay.
participants.
Good evening, Supradeep. We had a
Hi.
very candid chat. Now all the audience is joining in.
Okay. So it's very cold here.
Oh, okay.
So that's why we are trying to be serious before the audience.
How cold it is, Supradeep, there?
In Faridabad, it is, I think it is 8 or 9 now.
Oh, my goodness.
Hello, friends. Welcome you once again to the brand new episode of GICS Rapid Journal Review. Tonight, we are going to discuss on a very interesting subject which has been recently published in the NEJM. And this is not the first in the list because earlier there has been 3 randomized clinical trials on the same subject, the biggest one being the reality trial. And as you can well understand, that this is a comparison between conservative versus restrictive versus liberal transfusion in patients with myocardial infarction. Although earlier studies have looked upon different outcomes, including an all-cause mortality, this study, which looked definitely into a composite outcome of endpoint of all-cause 30-day mortality and recurrent MI, it has something interesting to tell. So we are going to hear about this trial from today's presenter. We are joined today by our expert panelist, Dr. Anop from Thailand. Welcome you, Dr. Anop. We are also joined by our regular panelist, Dr. Pradeep and Dr. Ajit from Bangalore. And today's moderator will be Dr. Supradeep Ghosh and presenter Dr. Saurav. So before we go into the discussion about here the presentation of the main MINT trial, we are going to have a preclude our discussion by starting with Dr. Pradeep, a small presentation on transfusion triggers in the ICU. Here we move on to hear from Dr. Pradeep Rangappa.
Good evening, friends. So I'll be talking on this topic, transfusion triggers in ICU. So this is a preamble to the journal that's going to be discussed, which is the MINT trial. So I wish to acknowledge my colleague, Dr. Manjunath, who helped me develop this content. So just to give a backdrop, there are at least 45 randomized controlled trials done in this topic. So I'll just take you through some of the key trials, which is of relevance and what is our understanding on transfusion. So when you look at the trials, so the first trial that talked about restrictive transfusion was the TRIC trial that came in 1999. And if you see, most of these trials are published in very good journals. So this came in New England NEJM. So in 2010, after 1999, after about 10 years, the TRACK trial came. So this was done, this came in JAMA. This was to look at restrictive and liberal transfusion difference in post-cardiac surgery patients. So that was a distinct set of patients they looked at. In 2011, FOCUS trial came again in NEJM, where they looked at the transfusion triggers between restrictive and liberal in hip surgery, or someone who is at a high risk of cardiovascular event in hip surgery. 2013, there was a study that came in upper GI bleed, whether there is a difference between the restrictive or the liberal transfusion. And 2014, the TRIST trial came, which was another Danish trial, came from Denmark, which was a comprehensive trial, which sort of dawned upon the clarity on our understanding. 2021 was the most recent. So the MINT trial, what which will be discussed, is little similar to reality trial. So you can little pay attention to reality trial, which is looking at transfusion triggers in someone with myocardial infarction with anemia. And 2023, there was this international guidelines which gave sort of levels of recommendations on the transfusion triggers. So this is sort of summary of the key trials that came over last 25 years. So we'll just go one by one. So the TRIC trial was the earliest trial. It was a multi-center randomized controlled trial of transfusion in critically ill. This was done by Canadian authors. So this study was done in 838 patients who were euvolemic and hemoglobin was less than 9. So here they divided the patient into restrictive group, 418 patients in restrictive group, where they gave transfusion if hemoglobin was less than 7 grams to maintain the hemoglobin range between 7 to 9 grams per deciliter. And the liberal, the number of patients was 420, where they gave a transfusion if hemoglobin is less than 10 grams. So the threshold was 10 grams as a trigger to transfuse blood. And they maintained hemoglobin between 10 to 12. So this was a restricted and liberal. And if you see most of the studies, they'll be following this sort of a pattern of 7 versus 10 as a threshold. Some of the studies have taken 8. The focus trial on the hip surgery has taken 8. So you'll see that. So when you look at the results of the study, so this was a positive study. 838 patients randomized between restricted and liberal. When they looked at 30-day mortality, there was no statistically significant difference between the restrictive and liberal. But when they looked at the subgroup, so they looked at stable patients where Apache 2 was less than 20. So which means they looked at less sicker patients. The 30-day mortality was much lesser in the restrictive. So which means to say if someone is less sicker. So they are the people who you should not be transfusing because these are the patients who had a worse outcome with unnecessary transfusion. And even the age. So in the lesser age group, here they looked at age less than 55 years. The effect was more pronounced in the restrictive group in improving the outcomes. As you see, the mortality, 30-day mortality was 5.7 in the restrictive as compared to 13 in liberal in younger age group. And in cardiac, they looked at the subgroup of cardiac diseases. They did not find any difference between restrictive and liberal. But hospital mortality also was significantly less in the restrictive group, 22.2% versus 28.1. So this was a study which sort of brought about this in a bold way that we should not unnecessarily transfuse and maintaining the transfusion threshold of 7 improves the outcome. So this was the first sort of a revelation that came in the TRIC trial. So after this, after many years, so this came in around 2000, after about 14 years, a similar trial came done by Denmark group called the TRIST trial, again published in NEJM, lower versus higher hemoglobin threshold for transfusion in septic shock. The reason I have taken up this in an order is because these are the type of patients we deal in ICU. Here, it was a little bigger study than the TRIST trial. So 998 patients with septic shock. Again, they took patients who had hemoglobin less than 9, so divided into lower threshold group and higher threshold. 502 patients in lower threshold where they transfused. It's very similar to the TRIC trial. HB less than 7, they gave transfusion, and higher threshold HB less than 9, they gave the blood transfusion. Little bigger study than the TRIC trial. Here, the only difference is they gave leukodepleted blood cells as opposed to the TRIC where they give PRBC. Primary outcome was to look at 90-day mortality. So when you look at the results, it was equivocal 998 patients, 502 in the lower threshold where transfusions were given when hemoglobin fell less than 7, higher threshold less than 9. So 90-day mortality, there was no difference between the lower threshold or higher threshold. And they looked at any adverse events like ischemic events, serious adverse events, and life support. So this was the equivocal trial, which basically said, like if you see the TRIC trial, it showed benefit in less sicker patients or in younger age group, and hospital mortality there was benefit. But TRIS trial said you either give no transfusion or transfusion or lower threshold or higher threshold. There was no difference with regards to outcome. And even with regards to adverse events like ischemic events or serious adverse, there was no difference. So it was an equivocal trial. So then we'll talk about this focus trial, which looks at liberal or restrictive transfusion in high-risk patients after hip surgery. This was published in 2011 by the US authors. So here they looked at the transfusion needs in patients who underwent hip surgery. So they took 2016 patients. So it's quite a big study, and patients' age group was more than 50 years who had history. So these are the hip surgeries who are at a higher risk of cardiovascular events and who had history of cardiovascular disease. So here they again divided into liberal and restrictive group. And if you see trick trial and TRIS, they put hemoglobin in restricted as 7 because these patients had a cardiovascular disease or were at a risk for cardiovascular. They took hemoglobin threshold of 8 as a restrictive and liberal as 10 grams per deciliter. Primary outcome, they looked at a composite of death and patient's inability to walk at 60-day follow-up after hip injury, which means they are debilitated and they could not walk 60 days after the surgery. So they took the composite of death and inability to walk at 60 days as the follow-up as a composite endpoint. So 2016 patients, so I think this is 1010, I think. So if you look at the transfusion requirements in liberal, obviously they had more transfusion. Restrictive, it was nil. So restrictive, they didn't have to give any blood. So primary outcome, which is a composite of death and inability to walk at 60 days, there was no difference between liberal. So this is also an equivocal study. It basically said you don't need to unnecessarily transfuse. It did not really change the outcomes. But they looked at hospital acute coronary syndrome, ACS events within the hospital and death. So even there was no difference between the liberal and restrictive. So someone who is at a risk of developing cardiac event within the hospital and death within the hospital, there was no difference because if you see the hospital mortality was better in restrictive in trick trial, that was not the case in focus trial. And they looked at 60 days follow-up, death after 60 days follow-up. Again, there was no difference between the liberal and the restrictive group. So this was non-significant between. So basically, the TRIS trial, the focus trial basically said either you restrict or you give blood. It did not have any bearing on the outcomes of any of these patients. And they looked at complications. It was similar between liberal and restrictive group. So then this is the most recent trial that came reality randomized because the whole argument for our intensive is, oh, this patient has cardiac history, so we should maintain a higher hemoglobin of 9, 10, so on and so forth. This study was done to address that. This came from the French group, effect of restrictive versus liberal blood transfusion on major cardiovascular events among patients with myocardial infarction and anemia. So it was a reality randomized controlled trial. The study was done in 35 hospitals in France and Spain. So they had 668 patients who had acute coronary event of some nature, and they compared hemoglobin of 7 grams versus 10 grams. So if you saw the trick trial 7 and 9, so TRIS 7 and 9, so focus is 8 and 10. Here they compared 7 grams and 10 grams. And out of 668, 30-day follow-up happened in 666. So there were two dropouts. And the median age was 77 years and the range was 69 to 84. 281, the 42.2% of the patients were females in this particular study. So the results in reality, 666 patients, 342 in restrictive, 324 in liberal. As you see, restrictive got 122 units of blood and liberal had got 323. So 99.7% of the patients had got blood in liberal group in this trial. So they looked at major adverse cardiac events. Again, there was no difference. So this is in patients who had MI, who had acute coronary syndrome, comparing hemoglobin of 7 and 10. So they did not find any difference with regards to major adverse cardiac events, and it was non-inferior. And all cause mortality, they looked between restrictive, there was no difference. It was 5.6% in restrictive and 7.7% in liberal. They looked at recurrent MI, which was again no difference between restrictive and liberal. They looked at patients who needed to undergo emergency coronary intervention. There was no difference, 1.5 in restrictive and 1.9% liberal. They looked at ischemic stroke, it was similar. So basically, in patients with acute coronary syndrome, either you maintain a 7 or 10, they did not really make a difference with regards to cardiovascular. So this trial is important because the MINT trial, which will be discussed by the speaker subsequently, is very similar to this. Even in MINT trial, they have looked at coronary acute myocardial infarction patients and seeing whether higher hemoglobin makes a difference. Obviously, we'll discuss on that. So this is very similar to that trial. This came in 2021. So now we'll look into this TRACS trial. So this came in cardiac surgery patients, again published in JAMA in 2010. So study done in Brazil and by the Belgian authors. So it's mainly done in Brazil, TRACS randomized control trial. So in patients undergoing cardiac surgery. So done between February 2009 to 2010. So they had 502 patients. So divided again in the liberal group, here they targeted hematocrit. So liberal group, they maintained hematocrit more than 30%, and restrictive, they maintained hematocrit more than 24%. Outcome, they looked at composite endpoint of 30-day all-cause mortality and severe comorbidities that patient developed, that the patient developing cardiogenic shock, ARDS, or acute kidney injury needing hemodialysis. So they looked at the composite. Like in the FOCUS trial, they looked at the composite endpoint of death and inability to walk at 60 days follow-up. So they took, like any other cardiac study, they looked at composite endpoint of mortality with other complications. So in TRACS trial, 253 in liberal, 249 in restrictive. The transfusion needs in liberal was 78%. In restrictive, only half of the patients got blood. So primary endpoint, which is a composite of severe comorbidities and mortality. As you see, there was no difference between liberal and restrictive group. It was non-inferior. But what this study tracks showed is number of blood transfused had an independent risk, was an independent risk for developing hospital complications and death at 30 days. And most importantly, they showed with every additional unit of blood transfusion, there was increase in the hazard of death. So hazard ratio of 1.2, and that became statistically significant, which means here they really looked at the correlation between the number of units transfused and the mortality, and they found with every unit that was added, there was an increase in the risk of death in this track trial. So that was a strong message that came out from this track trial. So if you see from all the narratives so far, all the studies are non-inferior because none of the studies showed, so except the TRIC study, which happened in 1999, we showed improved outcomes with restrictive transfusion. The SHOCK trial, the TRIC trial, the TRACS trial, none of them showed benefit with restrictive. Rather, it showed there's no difference between. So that's why the mid trial becomes relevant because there are signal towards harm in mid trial by being restrictive. There are signals, but it was not significant anyway that we discussed. So this is another study which looked at transfusion strategies for acute upper GI bleed. This came in again in NEJM by the Spanish authors in 2013. So they took 921 patients, randomized between restrictive and liberal, 461 in restrictive, 460 in liberal. So number of transfusion was around 51% in restrictive, and it was also, sorry, it's not a number of, the number of patients who did not have blood transfusion was more in restrictive, 51. So no transfusion, 51% in restrictive, 14% in liberal. So here, this was a hugely positive study. So until now, you're seeing equivocal. This particular study, they looked at 6-week survival was higher in the restrictive group in patients who had upper GI bleed. And this significance was found in patients who had bleed due to peptic ulcer or child A and child B cirrhosis, but not in. So this is one study, like trick study, which had a positive outcome in restrictive transfusion. So in upper GI bleed, you restrict the transfusion, they had a better outcome. And they looked at the risk of further bleeding also was less in the restrictive group, 10% as opposed to 16% in liberal. And the adverse events also was significantly less in the restrictive group. And in fact, they showed the portal pressures increased where patients were liberally transfused. So this was a positive. So until now, in my narrative, the trick trial was positive, and this trial, which came in NEJM on upper GI bleed, showed a significant benefit with restrictive transfusion because the survival was better in restrictive and the complications also were lessened in restrictive. So that is about the studies now. So now in 2023, they came out with these guidelines based on all these studies. And as I already made a mention, there are 45 trials done so far, randomized control trials to compare between restrictive and liberal, encompassing 20,600 patients, close to 20,600 patients. So this is the amount of data we have. And most of these studies have compared 7 to 8 versus 9 to 10 sort of a transfusion threshold. So the recommendations that come out is in recommendation 1, in hospitalized patients for hemodynamically stable, so the transfusion thresholds for the trigger should be 7 grams is acceptable. Only if it is less than 7, one should consider transfusion. So here they give a strong recommendation. Grade 1 is strong recommendation with moderate level of evidence, grade 1B. And in patients who are undergoing cardiac surgery, the transfusion trigger can be kept at 7.5 grams per deciliter is what the recommendation. In patients, and this particular recommendation came mainly from the focus trial where they compared 8 and 10. In patients undergoing hip surgery, so the transfusion trigger could be kept at 8 grams per deciliter. So these are the recommendations that came from these guidelines. The recommendation two is in oncology patients, also the transfusion trigger or threshold should be 7 grams per deciliter, and this is a conditional recommendation with a low quality evidence. Recommendation 3 and 4 are for children. Although I didn't cover any studies because we are all adult intensive. In children, just to remember, the guidelines are very similar. In critically ill children who are hemodynamically stable, who do not have hemoglobinopathies or who do not have cyanotic heart disease, the transfusion trigger, even for children, is 7 grams per deciliter. Strong recommendation with moderate level of evidence. Recommendation 4 is in patients with congenital heart disease. If they've had a biventricular repair, even there, the transfusion thresholds are 7 grams per deciliter. If a child has only single ventricle, then there is a higher threshold of 9 grams per deciliter. If a child has congenital heart disease which is not treated, even there, hemoglobin threshold of 7 to 9 is acceptable with low quality of evidence. So these are the guidelines based on 45 randomized controlled trials encompassing around 20,600 patients. So this is the take-home message for all our trainees. So 7 is good enough at this point of time because you saw all the studies which shows no difference between either you maintain 7 or 9. But now with MINT trial, anyway, after the discussion, it will possibly open up a little vista because there are signal pointing out towards benefit with being liberal. We'll anyway discuss about that. So thank you one and all. So I request you all to submit your valuable work to Journal of Acute Care, which comes out every 3 months. You can visit my website, www.drpadipangabra.com to read to this. So thank you one and all. And
Thank you very much, Pradeep. And now we are going into the main course of our today's journal club, and we are going to hear the MINT trial from today's presenter, Dr. Saurav Rai. And his moderator is Dr. Supradeep Ghosh. Yes, Dr. Saurabh, you can start your screen sharing.
Yes. Is my screen seen?
Yeah, please go ahead.
Good evening to all my seniors and all my colleagues. I'm Dr. Saurabh from Fortis Hospital, Faridabad. So today's topic of discussion is the MINT trial. So MINT trial is basically myocardial infarction and transfusion. So this was published in November 2023 in the New England Journal of Medicine. Restrictive or liberal transfusion strategy in myocardial infarction and anemia. So sir has told us in very elaborative manner regarding all the available evidence so far. Basically, the threshold for blood transfusion had been a long debated topic in critical care, but after certain high quality randomized controlled trials, 7 gram per deciliter has been the accepted standard of care in most facilities, except for patients with myocardial ischemia. Indications and thresholds for transfusion in patients with myocardial ischemia remain controversial due to lack of evidence. 3 randomized trials have compared transfusion thresholds in myocardial infarction and have shown inconsistent results. Theoretically, blood transfusion decreases ischemic injury by increasing oxygen carrying capacity, and on the other hand, blood transfusions could lead to fluid overload, adverse reactions, thrombosis from increased viscosity, and inflammation. So basically, this was all the evidence. So sir has already talked about it in a very detailed manner. Directly skip to the our main MINT trial. So basically now whatever evidence we have that for patients who have uh, for other patients except for myocardial ischemia, 7 gram has been the accepted trigger. Now the reality trial has shown that uh, restrictive transfusion is non-inferior to liberal transfusion. So now we are looking at the MINT trial. The clinical question what they asked was, in patients of acute myocardial infarction with anemia, does a liberal transfusion strategy as compared to restrictive transfusion strategy reduce the risk of recurrent myocardial infarction or death at day 30? This was an open label randomized controlled trial conducted at 144 sites in United States, France, Canada, Brazil, New Zealand, and Australia. The population included were adults 18 years or more of age, myocardial infarction, both ST elevation myocardial infarction and non-ST elevation myocardial infarction were included. Anemia with hemoglobin level of less than 10 gram per deciliter within 24 hours before randomization. Patients with type 1, type 2, 4B, or 4C myocardial infarction were included. 4C myocardial infarction, it was a term added in the 2018 fourth definition of myocardial infarction. 4C was basically stent stenosis, but without thrombosis. Not much evidence is available regarding this 4C myocardial infarction. Following patients were excluded: patients with uncontrolled bleeding, patients receiving palliative treatment, patients who were scheduled for cardiac surgery during the current admission, and patients who refused for blood transfusion. Patients were randomly assigned in a 1:1 ratio to a restrictive or liberal transfusion strategy by means of a web-based system. The authors determined that a sample size of 3,500 patients would provide the trial with 80% power to detect a 20% relative between group difference in the incidence of primary outcome, assuming an overall incidence of myocardial infarction or death of 16.4%. The risk ratios were used to assess the risk with restrictive versus liberal strategy, where with values more than 1 favoring the liberal strategy. They had already mentioned that if the values of risk ratio is more than 1, then it would favor the liberal strategy. And they had a very good matching of the baseline characteristics. They had done it very well. The mean age in both the groups, in the restrictive group as well as in the liberal group, was 72 years. 45% of the patients in both the groups were females, and similarly they had done the racial or ethnic group matching. Then in case of medical history, old medical history and comorbidities, they had done it perfectly well in terms of the known medical illnesses. This is about the history of angiography. Here, almost 27% patients in both the groups had ejection fraction between 30 to 45%, and almost 10% patients in both the groups had ejection fraction less than 30%. Now, this is very interesting. Non-ST elevation MI, almost 80 to 81% patients in both the groups had non-ST elevation myocardial infarction. And 41% patients, as we see, 41% patients in both the groups had type 1 myocardial infarction. But see here, type 2 myocardial infarction. Type 1 myocardial infarction is because of atherosclerotic plaque or disruption of the atherosclerotic plaque. And type 2 myocardial infarction, this is due to supply and demand mismatch. And we know that anemia is one of the main causes of type 2 myocardial infarction. So here they included 55% patients of type 2 myocardial infarction in this trial. And rest others, these were all good matching of the other characteristics as well. In hospital heart failure, mechanical ventilation, active bleeding, red cell transfusion, mean hemoglobin level, it was 8.6 on day 0, median creatinine values, and all these patients who were on dialysis. Now, basically what they did, in the restrictive transfusion was permitted but not required when the hemoglobin level was less than 8 gram per deciliter. Transfusion was strongly recommended when the level was less than 7 gram per deciliter or when anginal symptoms were not controlled with medications. Whereas in the liberal transfusion, 1 unit of red cell was administered after randomization to maintain the hemoglobin level at or above 10 gram per deciliter until the time of hospital discharge or 30 days. Interventions common to both the groups were that 1 unit of blood was transfused at the time, and then after 1 unit of blood transfused, measurement of hemoglobin level was done. And the transfusion protocol was paused if the managing clinician, if he judged that active bleeding required immediate transfusion. And transfusion was delayed in patients of volume overload till adequate diuresis was achieved, or in patients of end-stage renal disease till the patients were dialyzed. So this were the this in the above graph we see this is the main hemoglobin level. So as we see, this is the restrictive, the blue line, it is the restrictive group. This yellow line is the liberal strategy group. In both the groups, the hemoglobin level at day 0 was 8.6. And at day 1, the mean hemoglobin level in restrictive was 8.8, whereas in liberal it was 10.1. Here, it was on day 2, it was 8.9 versus 10.4 in the liberal strategy. 8.9, 10.5. And this is the number of units of blood transfused. On the x-axis, we see number of units of blood transfused, and here the percentage of patients. So as we see in the restrictive strategy, almost 66% of the patients received no transfusion. And see here, in the liberal strategy, obviously this was in liberal strategy, more blood units had to be given. So this was the average number of patients. Almost 33% of the patients received more than 3 PRBCs. And the total units received was 1237 units in the restrictive strategy, whereas it was 4325 units in the liberal strategy. It was, that means the number of blood received was much more in the liberal strategy. It was almost more than 3.5 times in the liberal strategy. And we have a meta-analysis as well of almost 21,000 patients, including the other trials as well, which says that the number of blood products used in the liberal strategy is almost 50% more than the restrictive strategy. Outcome. So the primary outcome was a composite of myocardial infarction or death at day 30. And the secondary outcomes were individual components of the primary outcome: death, myocardial infarction, revascularization, and rehospitalization. So here, this is the outcome. So we already know myocardial infarction or death was the primary outcome, and the 16.9% death occurred in the restrictive strategy, whereas it is 14.5% in the liberal strategy. So we see that in terms of numbers, the restrictive strategy, this had more deaths. But in terms of speaking, in terms of statistical values, this range was not significant. Then again, similarly in the other outcomes as well, the number of death 9.9%, 8.3%. That means deaths were slightly more in the restrictive strategy. But again, speaking in terms of statistics, this was not significant. So in all this, in myocardial infarction, death myocardial infarction, and other outcomes as well, these were the other added outcomes: heart failure, myocardial infarction, all these were not significant, except for, in terms of statistical values, they were not significant. But except for, see this is the cardiac death. So cardiac death was 5.5% in the restrictive strategy, whereas it was 3.2% in the liberal strategy. And this was these values were statistically significant. But here the problem is that cardiac death was not mentioned as primary, secondary, or tertiary outcome in their protocol. And all others were insignificant. But as we see in the statistical analysis, we had already seen that they had mentioned in the risk ratio, if the values are more than 1, then they were in favor of the liberal strategy. And we see all these numbers, they are more than 1. So all these numbers, although statistically not significant, but these point variables, they are favoring the liberal group. Similarly, here, they did a subgroup analysis which was pre-specified. So all these were pre-specified subgroup analysis of ST elevation, non-ST elevation, type 1, type 2 myocardial infarction, revascularization before randomization, heart failure, hemoglobin category. So here also, none of these was statistically significant, but the endpoint variables point favorable outcome towards the liberal strategy. But here also, this is this is an interesting point actually. If we see patients of type 1 myocardial infarction, that is patients due to atherosclerotic plaque rupture, type 2 due to supply and demand mismatch. Theoretically speaking, the liberal strategy should have helped the patients with type 2 myocardial infarction, because type 2 myocardial infarction, one of the cause will be anemia of demand ischemia. So theoretically speaking, liberal strategy should have given upper hand to the type 2 myocardial infarction. But here we see that in patients with type 2 myocardial infarction, this is almost same. This is not significant at all. But when we see in patients with type 1 myocardial infarction, see here, the restrictive strategy. The This is type 1 myocardial infarction occurred in 18.2%, where this one, 18.2 and 13.8. So this we are talking about primary outcome in this age group. So the primary outcome 18.2% in type 1 myocardial infarction and 13.8% in the liberal strategy group. So this was little odd. Then all other things, these were basically the pre-specified outcomes, and the primary outcome was not significant in all these subgroups as well. The trial showed no statistical difference in terms of primary outcome. Liberal transfusion strategy was consistently favored in point estimates for the primary and secondary outcomes in this trial. The frequency of heart failure and other safety outcomes were similar in both the groups, but more protocol violations took place in the liberal group. 13.7% in the liberal group versus 2.6% in the restrictive group due to fluid overload, dialysis, transfusion reactions. Restrictive transfusions have been the accepted standard of care in non-cardiac patients, but there is still uncertainty regarding the transfusion thresholds in patients of cardiac ischemia. 3 earlier randomized control trials, CRIT trial, MINT pilot study, reality trial. So sir has already talked about reality trial, which showed that restrictive transfusion is non-inferior to the liberal transfusion. CRIT trial was a small trial consisted of only 45 patients, but it favored the restrictive trial. The MINT pilot study, this was a trial consisting of 110 patients, and this favored the liberal strategy, and then reality trial. But when all these trials were combined, actually their sample size, it was much smaller, because MINT trials was 4 times larger than all these studies combined. Cardiac death was more common in the restrictive group, 5.5%, than liberal group, 3.3%. But again, as we discussed, it was not designated as primary, secondary, or tertiary outcome. And this was again when we are studying a population of myocardial infarction, in those population, fewer than half the deaths were classified as cardiac, and the rest of the deaths were non-cardiac. Trial was designed to detect a 20% relative between group difference. Smaller than expected difference may have occurred due to more heterogeneity, particularly involving a large number of patients with demand ischemia. The authors state that the trial analysis were not adjusted for multiplicity, so caution must be used in interpreting the results beyond the primary outcome. So the authors concluded that in patients with acute myocardial infarction and anemia, a liberal transfusion strategy did not significantly reduce the risk of recurrent myocardial infarction or death at 30 days. 95% confidence interval contains values that suggest a clinical benefit for liberal transfusion, but authors feel further studies are needed to confirm this. So strengths of the trial was obviously it had large sample size, good matching of baseline characteristics. Transfusion protocols were straightforward and easily manageable. The protocol made accommodations for patients of heart failure and patients on dialysis. Good follow-up. 30-day follow-up completed in 98.3% of the patients. Myocardial infarction component of the primary outcome was centrally adjudicated in a blind fashion. Basically, they made a committee which was blinded, and the committee used to track all the troponin values. And the committee did not know about the about the patients and the interventions. So this component, only myocardial infarction, was adjudicated centrally. Limitations: unblinded trial, interventions not masked from healthcare professionals giving care. Obviously, this could not be done. Death from cardiac causes was a pre-specified outcome, but not designated as primary, secondary, or tertiary outcome. Outcomes other than myocardial infarction not centrally adjudicated. Protocol adherence not followed in 13.7% of the patients in liberal transfusion group. Reasons were fluid overload, transfusion reactions, dialysis, patient preference, provider preference, blood supply shortages, and staffing issues. Approximately 55% of the patients in both groups had type 2 myocardial infarction, demand supply mismatch. Statistical endpoints suggest liberal strategy more favorable in type 1 myocardial infarction than in type 2 myocardial infarction, which is a bit odd. So, coming to the end, the clinical implications, that what should we gain from this trial? Should we change our clinical practice based on the primary outcome, that there is no difference? Or, considering the point variables, shall we follow a more liberal approach in patients with myocardial ischemia? Or is there a need for further study which separating type 1 and type 2 myocardial infarction with anemia? So we have already seen a lot of evidence, and again we have seen a trial. So I would like that sir or our moderator should focus on this aspect. So what should be our implications from this trial?
Thank you, Saurav. Thank you for your very nice presentation. I think
Thank
you
you, sir.
demand as much of congratulations for nicely presenting the study, as the investigators deserve to be congratulated for bringing out this wonderful trial, which is the largest randomized controlled trial. Can you please stop sharing your screen?
Yes, sir.
Which is probably the largest clinical trial. Initially, it was reality, and now MINT trial, to see the benefits between the two. Now, first thing, we are going to have a very detailed discussion on this. And as of now, I would like to start with our expert panelist for the day, Dr. Anop. We have seen this trial, and we have seen how this large trial was conducted, and how quite meticulously, I should say. But when you see 1/3 of the patients received transfusion before randomization, how do you think the course of the study can get affected?
I think as it's mentioned in the protocol, the hemoglobin level is measuring before the randomization, around 24 hours before randomization, and only the patient who had the anemia as defined the hemoglobin lower than 8 grams per deciliter only included in this study. So I think if the patient received blood transfusion before randomization, it might affect the level of the hemoglobin, and this group of patients may not include into the trial, and might affect the outcome probably. Yeah.
Yeah, so probably this is a very important consideration that we need to put because of the fact. But another important thing is what already Saurav has pointed out so nicely, and everyone has understood. I'll go on to our moderator, Dr. Ghosh. You'd understand as about the adjudication of MI. If you see the adjudication part, particularly in the setting where we're getting a borderline statistical significant value, how important this thing it is to have a proper adjudication as to regarding the cause of cardiovascular death, number one, and whether that cardiovascular death can be accounted for as due to ischemia or arrhythmias or whatsoever, and how to pinpoint and cover it to decide that this could have been a result of either liberal or restrictive transfusion. Dr. Ghosh.
Thank you, Anirban. There are very, very significant differences between the reality trial, which I believe is a very good trial, and which was actually done on patients who are having mostly type 1 MI. Majority of these patients, around 10 gram was the baseline hemoglobin in both the groups, and 80% of the patients in the reality trial, they actually underwent revascularization. So they were the real MI, what we think of as MI, myocardial infarction. And another thing is a large number of patients in the reality trial were actually the ST elevation myocardial infarction. Whereas if you see this trial, I congratulate the great trial, big one, very difficult to conduct, but a large number of patients, 55%, just for the sake of inclusion of a large number of patients, you are including 55% of the patients who are type 2 MI, who are supposed to receive transfusion. Mostly type 2 MI are because of anemia, a large number of them. So how can you combine a group of patients, type 2 MI, who needs transfusion, group of patients who requires revascularization? If you see the revascularization rate of these patients, they were less than 30%. So I don't know, can you combine Chane and Murray together? That's a very difficult things. So I'll take the regarding the Saurav has pointed out that the cardiac death, they did not define what do they mean by the cardiac death in the manuscript. And this cardiac death described by them was actually an exploratory outcome. It was not a primary or secondary outcome. So I'll take this outcome, that statistically significant result, with a pinch of salt. I believe this was a great study, but we missed an opportunity. Probably a separation of the two groups could have given us a better, more meaningful clinical things. But this study is important, and we decided to go ahead with the study because this is a very, very large, very large study published in this particular domain.
Absolutely, absolutely, Dr. Ghosh. And as I going on to Dr. Pradeep. Pradeep, as we know that reality trial, which was considered as a comparator for this trial, is indeed was a non-inferior kind of a trial. This was a pragmatic comparison, whereas in this trial, if you see one of the most important point which authors have disclosed twice, and most of the reviewers have also mentioned in their blogs, is the protocol discontinuation in the liberal therapy, in the liberal strategy group. So to what extent do you think that this protocol discontinuation in the liberal transfusion group might have influenced the results of the study? I will come with the same question to Ajit, but I want to hear from Dr. Pradeep first.
Yeah, so I think Anirban, as you said, I think I have to congratulate Saurabh for his excellent presentation, and Supradeep for his valuable comments on reality trial. So I think the protocol, I'm not sure whether there was any reasoning given, Anirban, as to the protocol.
The reasoning was given, too much of fluids, this, that, the reasoning was given.
So very often in any trial of such nature, which is conducted across many countries, and as we are emphasizing, this is possibly one of the largest trial because there are 45 RCTs, and this is the only trial which I think the hip surgery one was 2,000 odd patients. This is 3,504. So this is the largest. And in a study of this nature spreading across continents, there is always this protocol sort of a dilution that tends to happen. And if the reasoning is not very strong as to why this has happened, and so I wouldn't particularly believe this may have had a bearing on the outcomes, especially the composite endpoints that you are looking at. This is my submission to it, but I'm sure others, if have any difference, they can enlighten me on this.
I agree with
personally don't believe.
Ajit. Yeah.
So that's the so the hemoglobin here. See, for example, you compare a 7 to 8 sort of thing with 9 to 10.
No, Ajit, I am asking you a specific 17%, 15% or 15.7% protocol discontinuation in the liberal strategy group.
Yeah.
Is it normal or is it abnormal? What do you think?
That is abnormal. It can affect the study. It can affect the results. It can
Dr.
definitely affect the
Anop,
results. But what I mean to add to that is that even the making the protocol 8 or 9, 8 and 9 versus 10. That also again it just broadens the thing. So that dilutes the difference. Because, unless the difference would have been 8 or 9 versus 10. If it's 8 versus 10, it would have been more clearer. That's what I'm trying to convey. So that is there, and obviously the adherencies are only 2/3. Moderate adherencies there. That also definitely would have compounded a lot. Actually, unless we go to the details of that, we never know.
Dr. Anop, for 15.7% protocol discontinuation in the liberal strategy group, do you think it is normal or it must have definitely influenced the results? Yeah.
To be honest, I have no idea about the number of the 15% is normal, abnormal. But I think the reason that they mentioned in the manuscript is reasonable to withdraw the blood transfusion in patient with that reason. Yeah.
Dr. Ghosh, one important question that I want to ask you is that how valid do you think is this study results? Because in this study, they have excluded all patients with active bleeding, all patients with potential surgery or expectant surgery. So ultimately, these results remain valid for only a group of patients who have MI with anemia, without any bleeding, not planned for any intervention or surgery. Now, when you extrapolate the results of such a study and you mistakenly extrapolate it into other sections of the patients, do you think you get valid results?
Very difficult question, Anirban. But I can only say my personal opinion and what has been asked in the question and answer, I think by Kapil, that Kapil has asked what is our practice. I think our practice still continued to be that this study is not going to change my practice as of now currently. So I'll still continue to give blood transfusion to my patients with type 2 MI, and I'll still be very skeptical in using blood transfusion just by virtue of some hemoglobin value of 7 or 8, whatever. If the patient continue to have angina, which they allowed, actually they have allowed, if the patient continue to have angina, in both groups they allowed the blood transfusion. So I'll keep on giving the same thing. If my patient's type 1 myocardial infarction has continued to have angina despite revascularization, and he or she is having anemia, I'll transfuse. In type 2 MI, where there is a supply-demand relationship, where I have a belief that tropi is getting elevated because of anemia. So probably I'll be transfusing the patient irrespective of the study results. So, and this is the practice that we have been following, and I think we'll continue to follow the same practice. And I'll be waiting for another trial where these two groups will be separated.
Well, that is two groups can be separated. That would be definitely a good proposition. But Pradeep, as mentioned, Dr. Ghosh has mentioned about the tropi. So in these patients, post-randomization, they were over a period of 3 days. So it was the tropi was surveyed. So how do you think that this particular step could have influenced the results? Because it was a routine surveillance of tropi following randomization. Can it affect the results?
No, see, Anirban, I think everything was adhering to the protocol. I don't think that had any bearing to deviate from the standard of care. In
No, but
fact,
it
they
can
make a
detect
mention.
MI. But it can
See,
detect MI.
yeah, I know. So because even in the strengths of the study, the authors do mention about this, that they continued with their protocol even in hemodialysis patients, heart failure patients, or any other. So which means to say that authors were fairly particular about adhering to the protocol, and they did not divide. And maybe the dilution of the protocol, what you mentioned, I don't know if they have done subgroup and seen whether this is the group which where the protocol was diluted. Having said all this, Anirban, for the question you asked about adhering and dilution of protocol, the authors do mention in the discussion that one of the limitation of the trial, which in fact is quite surprising, they put it as a limitation, in the liberal group, their ability to attain 10 grams happened in 86.3% of the patients, which is extraordinarily good, if you ask me. but still they do submit that it was a limitation, which means it was a well-conducted trial and possibly it ticked most of the boxes. So obviously, there are some deviations, but they have tried their best, is what my submission is.
Fair enough. Fair. I'm going to Ajit with the same question. See, the study ultimately shows a 2.4% reduction. Whether it is statistically significant, it doesn't matter. In a 2.4% reduction by using a liberal strategy. And at the same time, it goes on to go a daily troponin levels for 3 days, which is normally not a practice. Do you think that this can lead to an over detection of MI in these patients? And as such, can the results get affected?
It can, yes. Daily you are checking it. So naturally, you can have an over detection can be there. Yes.
Dr. Anop,
Anirban, just to add, if your question is to say that cardiac related death, which Saurabh really emphasized during his presentation, was more in the restrictive group and that did attain statistical significance. Is that what you're trying to say by doing repeated troponin? They have tried to recognize this cardiac related death. Is that what?
No. It is about the detection of the MI, which can get affected because they're doing a repeated troponin over a period of daily. So it will lead to detection. And this has been discussed at length in the European Heart Journal as an editorial part in the as of this study. And definitely this is not a standard practice, and therefore this has been put forth as a reason by which the difference has been found, which would have not been found otherwise. But more important question that I want to ask Dr. Anop. Yeah.
Anirban, can I comment on
Yes,
this?
yes.
Because the SSRs were blinded, so they actually did serial tropi and ECG to pick up the myocardial infarction, and this is true for both the groups. And when the SSRs are blinded, what can you do? You can do
no, not the ECG. We are talking of the troponin.
So they did trop and ECG both, and those results were sent to the SSRs to make an independent assessment about the incidence of myocardial infarction in both groups, because this was actually one of the outcome. So this was actually required. How can you go for it? How can the SSR, because SSRs are not playing the clinical things.
What they have discussed about MI adjudication, if you remember. So this MI adjudication is all
they send both ECG and tropi. They send both ECG, and they have periodically sent ECG and tropi both.
So in the first 3 days continuously, if you send troponin levels, still you think that there can
it will be true for both groups. So it will be true for both groups. So both groups it was the same. So it should not affect any particular.
Fair enough. That is again a very controversial thing. Which, anyways, moving on to Dr. Anobai, one thing I again ask you about this study. In this study, do you think that if it is reproducible, if the same study is conducted at your place or my place, is it likely to produce similar results? Dr. Anob.
I think I wonder about the protocol a little bit in the liberal group. They continue to maintain the hemoglobin level at around 10 gram per deciliter throughout the 30 days of the study. I think after the patient has stable condition, maybe in this group of patients might not have to have transfusion. And the second one is the about the type 2 MI, that is the imbalance between the oxygen demand and supply. I think another concern is not just only the anemia, the hemoglobin level, but also other causes that can increase the myocardial consumption, such as the tachycardia or something like that can increase the myocardial consumption. It should be treated and should be mentioned what they do about these things apart from the giving just blood transfusion. And I think if it's reproduced in my institution, I think probably I should find the same thing. I probably think like that.
Yeah, thank you. But we are running out of time. I will quickly take some interesting questions from the viewer side. Kapil Devsodi asked, Dr. Anob, I want to ask you what combining type 1 and type 2 MI, where would one expect the effect size? Does combining the two affect the effect size, which is important for sample size calculation. Would you like to take that? Effect size estimate by combining type 1 and type 2 MI.
I think it's depend on which population that you want to answer the question for the benefit of the blood transfusion. If you think that the type 2 is the imbalance between the oxygen demand and supply, and the anemia is the cause, and you want to find the benefit from the blood transfusion, I think you should do only in the type 1 the type 2 type of the population, and of I think combine both can affect the effect side. Yeah.
So I think the most of the questions from the websites have been asked. Yeah, Dr. Pradeep, you want to ask?
Yeah, just need to make one comment. I don't know if Saurabh made an emphasis on this. I think if this study is read in detail by a cardiologist, he may adhere to giving blood to his patients, because the unscheduled interventions, coronary interventions, was more in the restrictive group, which most cardiologists wouldn't like. So, which means they had to do emergency PCIs for more patients in the restrictive group in this particular study. And then he reads it as cardiac death being more. So this may change the little bit of a practice, especially amongst cardiologists, is my submission, especially the unscheduled interventions that they had to do more, which became statistically significant in this study, Anirban.
Okay. So Kapil writes that effect size here is the point estimate of the primary outcome. So we know that primary outcome is a composite of death and MI, death at 30 days along with MI. So the point estimate of that can be the effect size. So to do that point estimate, combining type 1 and type 2, where would one expect the effect size? Something I think that this is not an easy estimate, because whether it will be a point estimate or a period estimate, we can only know if you look into similar studies that have been conducted. But fair enough that this needs retrospection. So since we are already out of time, before ending, I would like to all our experts to give their valuable opinion. I can see that we also have Dr. Kanchi Murli in the panel. So I welcome you also to join us and to give your expert opinion. But I will start with Dr. Ghosh. Dr. Ghosh, what are the key messages that you take from this MINT trial that are unequivocal? Yes, Dr. Ghosh.
Unequivocal is overall, in the overall population of myocardial infarction, the restrictive strategy versus liberal strategy has not shown any a great difference in the overall things. So we still need to individualize our patient.
Dr. Ajit, what are the key messages that you would like to assert from this MINT trial?
So that's it. So this trial also just it's failed to show any difference between the liberal versus restrictive strategy in acute myocardial infarction. But in my practice, and I teach students about keeping the hemoglobin as 8. I'm talking about non-MI patients, keeping the hemoglobin 7 as non-MI patients, and I'm okay with 7 to 8. I won't be angry if if the hemoglobin appears to be 8. But in the hemoglobin, the cardiac patients, I'll keep it between 8 to 9. Patients having myocardial infarction, I'll keep it in 8 to 9, maybe 1 gram, 1 to 2 grams more.
Dr. Murli, yes, I get you. Dr. Murli, can you hear?
Yeah, I can hear. I would like to make a few observations.
Yeah, please.
If you don't mind. First observation is that the authors have used the third universal definition, and currently prevailing definition is the fourth one, which was put forth in 2018. So I do not know whether this study started before the fourth universal definition came into vogue or after that. If it was after that, they should have used the fourth universal definition. That is one observation. Second observation is that the age group of the patient is 72 years mean in both groups, which is slightly different from our setups, where our mean age group will be about 55 to 60. That is second observation. Third observation is that as Saurabh has correctly pointed out, there is slight disparity between non-STEMI MI versus type 2 MI. They said that type 2 MI is 50%, but non-STEMI is 80%. 80% non-STEMI is somewhat very high as far as I can see. But most of the non-STEMI MIs have ST segment depression, and they are usually due to type 2. So that is, we have to find out what the details of this. The fourth observation is that there was no mention about cardiogenic shock. How many patients were in cardiogenic shock and what were the hemodynamic parameters, especially in terms of mean arterial pressure in both groups, so that we can know that how stable or unstable they were in each of the groups. The fifth observation is that I do not know. I'm just thinking aloud that parameters like cerebral oximetry or SCVO2 or SVO2 may also be utilized to dictate or indicate that the blood transfusion is necessary rather than the absolute value of the hemoglobin, because if the hemoglobin is low but the cerebral oximetry is showing good blood supply to the brain, I would not treat it with blood. These are some of my observations. Thank you so much.
Yeah, thank you, Dr. Murli. Your very good observations. I think some of them can be negated for the simple reason that this was a randomized control trial and it would have been anyway, it would have been affected equally both the groups. But yeah, definitely there are some important concerns that you have raised about the STEMI, high incidence of NSTEMI, and along with 55%. So I think these are, and the age also, this makes a difference. So yes. I go on to now. If I am left with Pradeep, your final observations?
Yeah, so Anirban, so looking into all the trials and now in the light of the recommendation that has come, I think I wanted to hear from Murli sir, because all this recommendation was encompassing a lot of cardiac condition in the kids as well. So 45 RCTs versus 1 and 20,600 patients. That's the data which has been distilled to come out with this recommendation. So possibly we would be sticking to restrictive strategy at this point of time. Having said that, there are important signals in this MINT study. I think two signals are important, which needs to be possibly investigated in the further trials. One is the unscheduled percutaneous interventions they had to do and the cardiac death. So if, as Supradeep rightly said, and you rightly pointed out, if there is an ongoing angina or if there is the anticipated ongoing ischemia of some nature, so these are the patients where I may try to err on having a higher hemoglobin based on this study. That would be my submission, Anil.
Dr. Anop, finally, your take home on the key points from this study, which one can assimilate.
Yes, I totally agree with Dr. Pradeep. Apart from the hemoglobin level, you have to look at overall clinical the patient. If the patient continue to have the symptom, even though the hemoglobin 8 or 9, you should treat the patient with the blood transfusion to ensure that the patient has adequate oxygen delivery. And the study give us some insight that the restrictive transfusion is not quite harm to our patient with the acute MI, and we can consider individually for each patient. Yeah.
Friends, MINT trial may not have changed our practice or may not lead into thinking of changing our practice, but definitely it has given us a food for thought and given up new avenues which need to be explored in deciding whether liberal or restrictive transfusion is going to benefit patients with MI. Considering the diverse circumstances, considering the diverse causes, and considering the diverse course of illnesses, these needs to be assessed further, and maybe we may get newer randomized clinical trials in the coming days. Thanks all of you for sparing your valuable time and joining us for GICS Rapid Journal Club. We are going to come back again as scheduled on our 4th Friday with another new article for discussion. For all of you from the desk of GICS Rapid Journal Review, Shubharatri, Shabar Khayat, good night.
Good night.
Thank
Thank
you.
you. Thank you, Anirban. Thank
Thank
you,
you, thank
Saurabh,
you.
for
Thank you,
excellent
Thank
Anup.
you.
presentation
Yes,
again.
Ghosh,
So
good
thank you,
night.
Anup, for joining.
Thank
Anup,
you.
you can share your
Thank
phone
you, sir.
number with Anirban. I'll take it from him. Thank you, Anup, for
No,
joining.
No,
Thank
no,
you,
thank
Anirban.
you,
Thank you, sir.
thanks.
Thank you,
Thank you
Kanchi
so
Murli
much.
sir, for
Thank you
joining.
so much.
Thank you, sir. Thank you.
Thank you, Anirban
hope
sir.
you enjoyed
Pradeep bhai.
Dr. Anup for the participation,
Yes, thank you very
because
much.
we would like to have you in our future discussions also in the
Of
coming days,
course.
whenever we have an
And
opportunity.
hope to see you soon in India sometime, Anup. Maybe in October, hopefully.
Okay.
Yeah. Thank you.
Thank
Thank
you
you
so
all.
much. Thank you.
Bye.
Bye.
Thank
Good,
you.
good night. Good night,
Good
everyone.
night, sir.